And welcome to today's live stream podcast of a Shot in the Arm podcast with the Global Health Council, coming to you from the World Health Assembly. And I'm joined again by my fantastic co-host, Elisha and Ben. Hey, Elisha.
Hey, Ben. Day two, still standing.
And who have we got in our magic bag studio?
We have our longtime friend and colleague, Mitchell Warren of AVAC.
Nice to see you both.
Nice to see you. Thanks for joining us.
My pleasure. Great to see the Shot in the Arm go to Geneva.
Right?
This is exciting.
When did you get in?
I got in just this morning, fresh off the plane.
Wow. Your energy levels. We really have to get some advice, perhaps on a separate podcast on how to cope.
They've always
with
been
travel and jet lag.
Pretty off the chart, Mitchell's energy levels.
Well, the chance to hang out with you two.
I know.
Yes.
Inspiring, isn't it?
Totally.
Motivator.
Anyway, back to reality, or not, as we are here in Geneva. So this podcast episode is about financing the global health response. And so we have news. A decision was actually made yesterday from the floor of the Palais de Congrès that the World Health Assembly members, the countries that make up the World Health Assembly, approved the budget for this year, which amounts to a 20% increase. Just wondered what both of your thoughts were about that. Is it enough? Should we be celebrating it? What do you think, Elisha?
We should be celebrating it. Is it enough? No. I think, one of the challenges that WHO has faced is that most of the contributions they receive from countries are voluntary. So it can really fluctuate from year to year. I think it's around a little over 80% of the budget comes from the goodwill of countries contributing. And the reason that we should celebrate this year in particular is that last year, there was a decision to slowly increase assessed contributions, which are essentially mandatory amounts of money that countries contribute. And so while countries approved that, everyone was kind of waiting to see if this year countries would go along with what the increase actually meant. And so they did, which was pretty significant in not just the financial piece, but also really showing commitment to WHO as an entity and an important one. The goal is by 2030 to have 50% of the budget from assessed contributions. So really bringing down that 84+% of voluntary budgeting.
Well, I want us to get into that in a bit of detail, and maybe there's something in the WHO press release about this that might reveal a few things. But Mitch, as you have landed in Geneva, what's your sense of this decision and the way in which financing for WHO is going?
Well, not to only talk about your podcast, but it is a shot in the arm for WHO, truly. And when I look back on the last 3 years, and just pre-pandemic or this pandemic of COVID-19, there was a lack of confidence in WHO. There were, it was really in a moment of crisis, I think. And I think that what we've seen in the last 3 years is, well, no actor has acted perfectly well, that WHO has really stepped up. And I think under Dr. Tedros's leadership, there is great evidence that WHO is beginning to show its worth to countries. And I think for me, and I think Elisha is exactly right. It is reason to celebrate, but it's not enough. We obviously, as advocates, will always want to advocate for a fully funded global health response. And this is not fully funded, but 20% increase in the current economic environment is a step forward. And separate from the amount of money, I think it sends a signal that people are beginning to have the confidence that WHO is an essential actor and needs to be funded to perform those essential roles.
Just so you know, we usually agree on almost everything, so I'm not sure how interesting
I'll try to say something that's going to be great, that will differ on.
It's going to be for people. It's not going to be that controversial.
Well, let's get into it. So you very politely referred to assessed contributions, and let's be honest about that. These are basically membership fees. And it was interesting that in the WHO press release, after assessed contributions, bracket membership fees, close bracket. And they haven't always done that. And I was rather pleased to see it. But do you read anything in the choice of words, the emerging choice of words?
I mean, from my view, I think there's, as part of this call from WHO to get beyond the voluntary contributions, several member states, including the US, have called back to WHO saying, as members that contribute, we would like a greater degree of transparency. We would like to understand, where the money goes, what the impact of the money is, which hasn't always been part of what WHO has been able to provide. So I think that might be some of what you're seeing. And also to Mitchell's point about, during the pandemic, countries really feeling like they needed a bright light and a sort of collector that got everybody together and on the same page. That's part of what a membership organization does, right? I mean, you're contributing to the greater whole. So it is, literal yet symbolic at the same time to have those brackets. Whenever you have brackets in an official document, it's like, well,
begin to worry.
remove all the brackets at the end.
And I think, one of the things, and what Elisha's, I think, leading to is this issue of, when more money's on the table, the expectations go up.
Mm-hmm.
So, and the transparency will need to increase. And is WHO delivering impact? I think we've seen a number of examples in the last 3 years that I think were steps up for WHO. But now with more resources, there are going to be even higher expectations. And so when governments, if they actually make good on their payments, and that's always a question mark, they're going to have expectations that certain things get done in certain ways. And so I think that is one of the double edge of having more money is more eyes on you and more need for transparency and more need for impact. But different people, different countries have a different litmus test for what is transparent and what is impact.
Yeah, totally. And we're seeing that playing out on the field, on the floor, as it were. But it does speak then with the increasing spotlight on WHO, and whether it's fit for purpose, and whether this august institution developed after the Second World War really has the mechanisms and has the structure to do what's required. And from my perspective, I'm really pleased that we are moving to a situation where WHO is driven by membership fees. The idea that 80% of their work had been through voluntary contributions. And, a lot of those had come from our friends on the West Coast, the Bill and Melinda Gates Foundation. And if you think about it, it was absolutely absurd that Gates was driving funding so much of the infectious disease response. They stepped in, and I think we should be hugely grateful to them. But of course, it raised questions about transparency and accountability. And, WHO is a multilateral institution. It needs to be funded that way. It's not the global fund. Yeah. It's not a partnership.
Well, I think that for me, in thinking about this global health architecture, you've got the global fund on the one hand, you've got a new pandemic fund on the other, and you've got WHO, and none of them replaces the other. How do they all act together? And how do you get the impact in global health, not just from any one agency? And so the dependencies on delivery are huge. And of course, at the end of the day, WHO, the pandemic fund, and the global fund, just as 3 examples, and there are many other actors.
Well, we're in UNAIDS, and before you disappear into a cloud of black smoke for not having mentioned UNAIDS, they are also part of it.
They are indeed, and one of the more complex entities, as you well know, by being a co-sponsored agency as opposed to a multilateral all by itself. It's got all the multilaterals, feeding up into it, and in the midst of that, who's delivering health? At the end of the day, it's not UNAIDS and WHO and the Global Fund and the Pandemic Fund. They're hugely important instruments in this architecture, but it's about the countries. Who's providing the resources, who's both financial and technical. And so when we think about how to have impact, and if I were a government funding WHO and said, I want to know that my investment in your agency is delivering something, at the end of the day, that delivery is somewhat out of WHO's full control, or UNAIDS or Global Fund or Pandemic Fund's control. So I think that for me, this is something we all know, but I think the global health architecture has never been more ripe for transformation. And I think for me, the next couple of years are going to be ones that we will all look back and judge either well or harshly if we designed, and what you said earlier about WHO, is it fit for purpose? I'm not sure any of these agencies are fit for the current purpose. It's a matter right now of reimagining the purposes and the fits for all of those agencies.
And as long as we don't try and make them fit for purpose for the last pandemic.
Yep.
Yeah. But I also get a sense that, and you've both referred to this, that the broader geopolitical context, the polycrises era that we are in, is also factoring in here. And, we've seen that in the WHA discussions. Elisha, you didn't get much sleep last night.
Not because of the discussions, just because of jet lag. I wasn't tossing and turning over the negotiations.
But you also raised a question of clarity that you wanted to make about that did keep you awake last night.
That did. So for those who know me, I really value precision. And yesterday we were talking about an intervention made by the Russians around protecting their sovereignty. That did happen, and I did mention it, but I mentioned it happening in the wrong session. So the conversation on sovereignty happened in the Strategic Roundtable on Pandemic Preparedness, not in the Committee on Global Women's and Children's Strategy. So thank you, Ben, for letting me correct what to everyone else probably seems like a ridiculous correction, but for me, it was really playing in my head.
And interesting, nonetheless. That a country like Russia should be talking about sovereignty.
Well, and I actually feel that was an even odder situation, because that conversation was around the pandemic accord and, revising the international health regulations, which kind of feeds in then to today. We saw a resolution being offered from Ukraine and its allies to, shame Russia, which is rightful for the ongoing health crisis they're creating in the Ukraine by their aggression. So there's, a through line in all of these, even if they don't happen at the same time. But yeah, it's just unfortunate that we're not, getting to peace, really.
It is interesting that we really visibly see this. It's not the first time it's happened, but Russia absolutely targeted the health infrastructure of Ukraine as a way of bringing the country to its knees.
Yes,
which it
absolutely.
Didn't succeed in, largely in part to the work of community-based organizations that filled the gap where it was needed. And Mitch, I don't know from a US perspective that whether you're seeing that politicization of health is affecting the way decisions are beginning to be made now, or further decisions are being made in the US?
I wouldn't say it's beginning. I think what we're seeing is now year 3 of, not just in the United States, but globally, the politicalization and the weaponization of health and health decisions. And you can see it playing out in any number of ways. And we didn't need a new pandemic in COVID to teach us that. We didn't need a Russian invasion of Ukraine to tell us that, but they all, anything, a pandemic or a war, shine lights on things. And they think they really are shining lights that it tells you the power of health. And I think as a health advocate, I think we need to look at this and be both shocked, alarmed, concerned, but also realize that if politicians are weaponizing health for any number of these reasons, we are working in a sector that actually is probably more powerful than we sometimes think about. We often think that we're on the margins. Well, we're not. We are center. As a royal we, as a collective.
Thank you.
Yes, I thought about that. Royalty is very important these days, Ben. It is really essential that we think about that, and then we need to flip the script. We need to see, well, if people are using it for harm, whether that's a Russian invasion, whether that's the way the past U.S. administration and other governments around the world weaponized the COVID response, how can we use the power of the health response to be a force of good, which of course we all know it to be, but it isn't necessarily done that way in general terms.
Well, and you've taken the conversation in this direction. So as you know, this is an issue I've been really passionate about for the last couple of years, and making sure that global health is central to our understanding of global security in this new era: environmental health, societal security and health, political military security. And I've had a lot of pushback from people who, I think to some degree rightly say, well, it's not about security, it's about solidarity. But the question is, how do we get a seat at the table where the trillions rather than billions are being talked about, and where we absolutely know that the contribution of health is central to building safe, secure, educated societies.
Well, I have to say, I would have, if you asked me 2.5 years ago, I would have said that COVID-19, for all of its devastation, economically, politically, and health, would have been an opportunity for people to realize, because we had a pandemic that was affecting everybody. And we've all worked in pandemics that don't seemingly affect everybody. They affect people who are poor and marginalized. And all of a sudden, COVID was affecting everybody. And I, perhaps in my naivete and my optimism, as we all have to be as advocates on some level, would have thought that the COVID response would have been a great reminder that this is not a health issue. This is about security. It is about stability. It is about solidarity. It's about all of those things. I now look 3 years later and realize that we are on the precipice as a global community of having lost that, of people kind of reverting back to their norm, because it's no longer seen as affecting them. And we talk about HIV, about TB, about cholera outbreaks. And if you are living in the United States, if you're living in the UK, if you're living in a number of wealthy countries, you're not thinking about HIV, TB, and cholera, but you thought about COVID. And I'm disappointed, but perhaps in retrospect, not surprised, that the global community is reverting to type. Perhaps not completely, but we need to keep pushing on that, because I think your point, whether it's, and I don't think solidarity or security need to be seen as either ors.
No, different sides of the same coin.
Mm-hmm. I think it's interesting too. I mean, I agree. One of the things that, in COVID, unlike but similar to other pandemics, because COVID did affect everyone, I think there was a lot of conversations around equity for a general population that we haven't seen with HIV or TB or, malaria or other things that we kind of think happen to other people, which is not the right view, but that's often what we think. Now, in the countries that Mitchell mentioned, we've kind of moved past the pandemic, as we think, and we have a little bit of, fatigue about talking about it. It's not really there. It's not a problem. Unfortunately, I think we also have equity fatigue because of that those conversations that bubbled up in developed countries about, hey, this health system is really unfair and people can't access it and we're not all together, like we've been pretending all along. People don't want to talk about that either, right? So, we're just moving past that and reverting to everybody's in their disease silo. And yes, we need to strengthen health systems, but we'll do it for TB, we'll do it for MNCH, which is the wrong thing to do and not the lesson that we learned. We learned that we need to be able to have health systems that can prevent and respond to an emerging threat, but they can also maintain essential health services at the same time. And it cannot be one or the other. So we've got to change that as advocates.
There's a risk here that we are falling into a repetition of the 1918 flu, where so desperate was society to get over this crisis that a collective amnesia settled. And while I don't think it'll be an amnesia because of all the various digital and social and other technologies, and including podcasts like this one, I do think you're absolutely right, Mitch, that there's a stepping away, and there's something similar, and I see it here this week. We're sort of not the center of attention anymore. There's not the kind of major news coverage happening around the WHA. And okay, the WHA is as dry as a Latin textbook, but given the things that it's having to discuss at the time coming out of a pandemic, that's a bit curious, isn't it?
Well, it's curious, but it's also, I think, in part because people have kind of gone back into some silos. So you could spend an entire week tracking pandemics. You can spend an entire week talking about TB, about HIV, about the health workforce. All of those issues are critical. I think one of the things, that we all think about, and certainly through Elisha's work and the Pandemic Fund, thinking about the connective tissue of those issues. At the end of the day, yes, we need to build a health workforce. This is not about an HIV response or a TB response or even about pandemics. This is about the right thing to do. And I think we do I think it's going to take some time, but I don't think we have the right narrative. I don't think we have the right narrative as advocates because we've gone back sometimes into silos. We're seeing this play out, as the conversations in the United States look at what should be the AIDS response versus health security, the issue you were raising, Ben, and where leadership should come. And there's a debate there. Oh, we could lose focus on the AIDS response if we focus on health security. Absurd. We need to do both of those things. And I don't think I think that we need to up our I don't want to, it's not a game. We need to up our approach to how we really get at these issues. And I think that future pandemics will win if we don't reflect on and build something differently out of the last 3 years.
That's absolutely, I agree. No, but it's interesting that you mentioned the 1918 influenza pandemic because that actually went to 1924. But we always just say the 1918 flu epidemic, like it was just 1 year and that was over. But it's very similar to how we talk about COVID. Oh, that was 2020, right? So we're past that, and it can't be one or the other. And I think we've talked about this on the podcast a couple of times. Like HIV is a pandemic, TB is a pandemic. So it's not that we're only dealing with emerging threats. We have things that we need to address now, and there's no guarantee that the next emerging threat is going to be an airborne virus similar to COVID. Like we don't know. So we really need to be prepared. I mean, I know this is hard for human beings to like innovate, do something new, think outside the box, especially in bureaucracies. It becomes very tricky, but we've got to be really ready. And it's not about a particular disease or a particular strain. You have to have the resilient building block that can tackle it. Right. And that's what we don't have. And we really learned that in COVID.
Yeah.
So this is a very hard conversation for me because, and perhaps this is my turn to disappear into a cloud of black smoke. I was a passionate, one might even say aggressive AIDS exceptionalist at the turn of the millennium.
I feel like this is a confession.
Yes,
Public health professionals.
And I was honestly really disappointed that the Global Fund included TB and malaria because HIV was something so unique. Well, okay, TB was a co-traveler, but malaria was a public health problem that we had failed to solve for decades. And I realized that in 2022, HIV was just an example of the kind of polycrisis that is emerging. And this is perhaps where I disappear into a cloud of smoke, that the way forward is for us to join the dots. And preparedness means universal health coverage or universal health care, depending on when we get onto that debate tomorrow. But that's a central component of it. Trained healthcare workers, accessible services, and trust in those health facilities are going to be as key as anything else. And, and if there's one thing that I think this particular WHA can achieve, it is joining the dots between the various topics that it's discussing here. I mean, earlier, Elisha, we were joking about the way the WHO calendar is, the WHA calendar is getting completely lost and off track. But the idea that pandemic conversations taking place just prior to UHC, universal health coverage conversations, that's actually a good thing, isn't it?
Yeah, I mean, I think those have to work together. I think taking place before or after it's a good sign that they're both taking place the same week, right? That there's a day talking about public health emergencies, there's a day talking about UHC. The challenge, though, is going to be bringing them together at the end. I mean, of course, you can't talk about everything at once, even though today, from what I hear, they're trying to do that. All the agenda items bundled in one session. But I think to your earlier point, Ben, about exceptionalism, I think the challenge with that for any disease is that people are not the disease, right? And so when you're in a health system, if you're getting treated as HIV, TB, obesity, NCDs, whatever, then you're never holistically seen as someone who should be healthy and have well-being. And so if you look at primary healthcare, as the pathway to UHC, really should be to look at the person as a person and just address whatever health ailments they may have. And we all know too that usually people don't have just one disease, right? There's comorbidities and you're at risk for many other things. And so there is a real, I think, advocacy component on exceptionalism, that you're bringing attention and awareness to something that may not have been, and you need a strong force behind that, especially if you're trying to mobilize resources and reduce stigma. But in the delivery of services, exceptionalism becomes very tricky as a person accessing the healthcare system.
You've got this remarkable tension that can actually be very good if we actually collectively get our act together. And that is, these conversations are happening about systems for health. And what Elisha is just describing is, I think, one of the things that the HIV community has taught us really well, which is what does person-centered care need to look like? And we know that many of the greatest successes in developing antiretroviral clinics and programs was that they were providing a lot of other things too. Yes, they were funded through PEPFAR or Global Fund or other AIDS responses, but it became a very people-centered response. And that was out of patient advocacy. It was out of the realities on the ground. So you've actually got multiple conversations, but two overarching threads. Where do health systems intersect with the people? I mean, to put it really simplistically. And all the conversations are rightly happening, whether it's this week or whether it's going to be in September at the United Nations, where we have 3 high-level meetings almost concurrently around TB, universal health coverage, and pandemics, which, 3 important conversations. And you can take a systems approach to that and say, wow, we need infrastructure for research. We need infrastructure for healthcare delivery. We need an infrastructure that include health workers. Or you could take a people-centered approach and say, what does the person need? And we are not yet there, but I hope that we can figure out, it's not a systems orientation or a people-centered orientation, it's how do those two intersect? And I think that, to me, is the future. If we can figure that out and if we can fund that and do it well and do it right.
And we need to get our advocacy together to be clear that we're advocating for that rather than our own niche subject. Elisha, one of your members, Research International, were guests on my podcast a month or so ago, and I got told off, and rightly so.
What did they say to you?
Because I was framing some of the questions in a way of, well, why should we take reconstructive surgery seriously? How do you argue your case on a list of priorities? All right, no, Ben, we have to think of this really holistically. We have to be thinking about how we fit together. It was really instructive to me.
I mean, I would say too, I think, to both of your points about the holistic piece and funding it right. We cannot do that if all of the decisions are made without community engagement. And so you mentioned this when we started, sort of the divide between the global health bureaucracy and architecture and what happens at the local level. And yesterday, Lois Chingandu from Frontline AIDS, she said the same kind of thing of like, what are we doing here when there's things to be done locally? And that's really true. I mean, there's got to be a big piece of the push from the global health community to really bridge that divide, because it's not correlated at this point. And there's a lot of decisions made in world capitals that then when they reach communities say, well, this doesn't work for us. This is not what we needed. This isn't what we asked for, right? And we've got to stop doing that. Unfortunately, so far this week, I have heard very little of that. And I see presentations from, scientists and policymakers and WHO folks and others who are saying like, and we've designed this new surveillance and we've designed this. And then say, well, were communities involved? Oh, no, this is just the beginning. We'll get to that. But it's at the beginning in the design. It needs to be co-created and co-designed and co-delivered. And so that's another change in the global health architecture that is ripe for transformation.
Absolutely. And not to go back into your black cloud, Ben, of AIDS exceptionalism, but that if there's anything we've learned from 43 years now of the HIV response, it is that when communities lead and when communities are engaged from the beginning, you get the right kinds of programs, the right kind of change. And that is one of those pieces. And I think for a number of us who've looked at the future pandemic response and pandemic fund architecture, this issue of what are the lessons? And the AIDS community has not got everything right ever, but we have done a lot of the right things in the last 40 plus years. And that community-centered approach is essential. And that's about decision-making. It's about governance, about accountability. So there are a lot of conversations this week. All the countries are here with huge delegations, and the community perspective is holding them to account after they leave Geneva, because they will say all sorts of great things. From every country. This is not an issue of rich countries or poor countries or northern countries or southern countries. Politicians will say all the right things sitting here in Geneva, and it is communities that will hold them to account. And that is something that the HIV community has done well, I think, historically. And we need to make sure that translates and magnifies and amplifies as we connect all those dots across these health issues.
Yeah. So you've just arrived, but one of the things we're going to do is just check in on the receptions that we've been to, the people we've bumped into, and the word on the street that we've picked up. Elisha,
Yes.
where were you last night?
Well, I was here with you doing the podcast. Before that, I stopped by a reception that Google Health was doing, which is, and I actually met with someone from their team today, and it's really interesting. I mean, I don't know why I had not conceptualized this, but thinking about how many times a day I say, oh, well, just Google it, right? When it comes to health information, they are sort of the front line for so many people. So they've been doing a lot of work on, ensuring there's credible information and that kind of thing, and trying to figure out where WHO fits into that. So I think that's really terrific. And I have actually been hearing quite a bit about digital health this week from side meetings and other conversations, which also feels pretty long overdue for the global health community. I mean, in the United States healthcare system, we hear a lot about digital health and, electronic medical systems and telehealth, which all came up during the pandemic across the world. But it feels like there's all of a sudden like a real momentum for that.
And I'm really, really pleased to see that. I mean, in some of the other work that I've been doing, looking at attitudes and emotions coming out of COVID-19. To your earlier point, Mitch, about the engagement and leadership of communities coming out of the AIDS epidemic, we did our own research. And these days, people are absolutely doing their own research. And Doctor, you may think that, but I've done my own research. I have spoken to Dr. Google, and I don't know how many times I've heard that phrase. So it's really good that they are here, and that there's going to be, inevitably, whether it's artificial intelligence, whether it's electronic medical records, there's going to be so much that's going to transform dramatically our world.
Well, it's funny, and this was not at a reception because I was on an airplane last night, but I think one of the things that comes up, and I think the Google example is a great one, that can be used as a great force for good. It can also, as we've seen in the last 3 years, be a force for evil in the way that misinformation has spread. I do think that this is a remarkable opportunity for WHO and for all of us working in global health to really rethink about the science and art of communication. Again, another plug for a podcast, but we think of communication often as the kind of external relations part of an organization, but communications is central to the global health response. And we've always known that fundamentally. I mean, I come from a social marketing communications background, so I always thought that. But certainly the COVID pandemic really, I thought, brought front and center that the investment in social science, behavioral science, communication science has been underfunded, neglected, often not even on the agendas of meetings like this. Yes, we need to train more health workers, but we also need to train better communicators.
That's right. I absolutely agree that is a key lesson coming out of pandemics, of this age of pandemics, and we forget it at our peril. Precisely to your point at the start, Elisha, around all these initiatives being developed, and now we will bring in community.
Right.
So, well, I know, Mitchell, you need to get on to the meetings that you have scheduled this afternoon. I know, Elisha, you've got more receptions and events that you actually need to speak
That sounds
at.
more fun.
You see, you say that. But one of the receptions I went to on Sunday night, it actually turned out to be a panel session.
Mm.
And
Oh,
so
tricky.
there weren't enough chairs. I was holding a glass of wine. And after about 30 minutes, my feet were killing me. So note to organizers of receptions here at WHA, if you are going to do a panel discussion, please provide enough seats for us all.
Absolutely.
Seats and wine. That's the secret.
Seats and wine. Okay, well, on that merry note, thank you, Mitch, for joining us.
Thank
I've
you
been
both.
trying
Thank
to get
you,
you on the
Mitchell.
podcast.
We finally did
We
it.
did it, yes.
It took us to be in Geneva, but we did
Yeah.
it. No, this is great. Great to see you both.
And Elisha, thank you. as
Absolutely.
always.
We'll be back again tomorrow.
We will indeed. So you'll be able to find this live streamed, of course, but also it'll go out on all the usual podcast panels and platforms later. So thanks for joining us, and we will see you tomorrow.